Welcome back to the Dr. Beau Show. I am Dr. Beau Beard here at the farm in Birmingham, Alabama. And today we're talking about pain and how pain is normal. This comes up a lot in our practice. It's come up more recently, at least in my purview, in particular with children. So if you look at the statistics of, everything from how much less frequently children are moving, how many kids are in pain, and maybe there's some ties to the obesity and overweight rate in children. But one of the things we've been talking about in our practice is, we've seen some kids that we get them out of pain. Modulating pain, getting rid of pain in a lot of people, most people, is pretty easy. But then when we're talking about kids, maybe even easier because they have a really plastic system, in particular, a plastic neurologic system. So getting them out of pain, taking away a feedback loop, which we're going to talk about, and then allowing them to do something sometimes leads to bigger injuries if there was an injury tied to the pain to begin with, which we'll also talk about. So pain is normal. So first, before we even talk about pain, we have to talk about, well, what's the difference between nociception and pain? So nociception refers to, I'm going to go ahead and share my screen here. So let's go over and share this. So nociception, as we can see, this is out of the Journal of International Association of Study of Pain. And I'm going to put links in the comment section below. When we look here, nociception refers to neural encoding of impending or actual tissue damage. So impending or actual. So noxious stimuli, that's nociception. Pain refers to the subjective experience or of actual or impending harm. So we have nociception, which is the neuronal kind of physiology that's occurring due to what they mean by impending is you're doing something that's going to lead to harm. There may be an emotional, psychosocial state of something that's happened before or that seems threatening that leads to the perception of harm. And then we can talk about chronic pain and things like that too. And then pain is actually that subjective experience, which makes pain really hard to pin down because obviously the subjectivity of it makes it different across a lot of different people, also across species, which we'll talk about as well. So that's the quick and dirty on nociception versus pain. That's a good jumping off point because we need to also realize that, let's talk about vision for a second. So vision is not a concrete representation of the world. It's an abstract perspective or perception of the world. So your eyes are taking in light, photons, and then you're perceiving those photons to determine that, well, in front of me is a camera and a microphone and a computer. But that's not really what's going on. You're seeing, we're bringing in light via neuronal tissue. Your eyes are outward facing parts of your brain. That's a big thing to understand, that we do not experience pain at a surface level. It's subjective. So that's the first thing. Now let's back way up on this. So why is pain normal? Well, when we look at, the idea of pain being tied to an important part of our evolutionary process, like you can go clear back to the first microscopic organisms in particular that can move. So when we look at these amoeboid structures, cyanobacteria, things that created the first motility and mobility within the biological system of Earth, which is like 3.5 billion years ago. One of the first things that started to happen with that is when, prey-predator relationships came about, noxious chemicals, which noxious stimuli, nociception, that things move away from things that are threats, right? That's important. Why? So you don't die, you stay alive. And pain is just a perception of that, right? It's the ability or a sensation to keep you safe. So it is absolutely necessary. And when we look at this paper from, what is this out of? Department of Integrated Biology and Pharmacology. So evolution of mechanisms and behavior important for pain. If we go all the way down, let's just kind of go to the juicy bits here. So it talks about two of the obstacles when we're talking about why is pain important from an evolutionary standpoint. Well, one of them is that it's just the ability to define pain because of this subjectivity of it, right? The subjective nature of pain makes it hard to say, well, how are we going to clinically study this thing? The second one is what they would determine is like what they say is the special status of the human species, which is basically, I think, just going in depth and saying, besides pain being subjective, then we have N = 1, that everybody has their own personal perception, subjective responses to pain. So it's not just species related, it's individual related. And that's, you know, when we look at species studies, when we look at rat models, rats are going to act pretty much the same across a lot of models, in particular with pain, right? Shock rat acts a certain way. With humans, it's not quite the same, right? There's internal motivating factors, social cues, all these things play in. And that's again where things like the biopsychosocial approach to medicine, conservative musculoskeletal care, therapy have come about, because we realize that it's not just this mechanical, neurological, psychological, like they're all tied together in what we would call a human. But again, I tell my patients when we're explaining rehab sometimes that, like, if you thought about yourself as a caveman, if you hurt your ankle elicits pain. So you stop moving, so you don't cause further damage. You also have other physiologic responses to help that. You swell to cause a splint, right? You swell not only to bring those inflammatory and then anti-inflammatory agents there, but also swelling creates lack of movement, which then helps you heal, much like a cast would. But while you have pain, you're not going to do certain things, which is beneficial. But at a certain point, your body is led by other primal urges, such as hunger or safety, and you may start moving on an ankle that doesn't feel awesome. Well, welcome to rehab, right? So if I had to catch back up with the tribe or evade a saber-toothed tiger, I would start moving around on that ankle, even if it didn't feel awesome. So I would then try to override a pain mechanism that's being driven by a better primal urge. Well, guess what? We don't have a whole lot of these days. We don't have a whole lot of primal urges driving us through or beyond a sensation that needs what we would call maybe gated or mitigated neurologically to then help us do certain things. So that's the evolutionary role of pain. Talking about pain and nociception, you're not going to get out of that conversation with then explaining, okay, is pain always tied? If we back up to that description of nociception, remember that impending or actual tissue damage, and then pain, again, same thing, actual or impending harm. So if we take that into account, we've got to talk about, well, what's the correlation between pain and pathology? It's poorly misunderstood or poorly understood, which means it's commonly misunderstood, that we don't really know. We do know that it's not always tied to pathology. We know that it's sometimes tied to pathology. The statistical analysis and how often both of those occur is kind of, it's up for grabs at this time. But some of the studies that we use in the clinic to talk about this are like this one right here. Results showing, this isn't a huge group. So there were, how many people do we have? 49 volunteers, not a huge group, looking at MRI findings. These are people that had 10 years. Oh, here we go. So history of low back pain, 10-year longitudinal analysis of the relationship between MRI, magnetic resonance imaging, and low back pain. So what were the basic findings? When you compare the low back pain history group with the group that didn't have low back pain, there was did not have a significantly increased prevalence of disc degeneration, disc bulging, basically degenerative change following baseline MRIs for the people versus the people that didn't have any back pain. And they've done types of these studies different ways, right? That we take, certain amount of people and we image them, and then certain people have imaging findings, right? They'll have disc herniation, bulge, degenerative change, modic changes. Some people won't. Some of the people that don't have those changes still have a subjective pain response. So it's, again, poorly understood. Now, if you have an acute injury, say you sprain your ankle, let's take that as an example again, and there's swelling and there's bruising, we can almost assure that there's some pathoanatomical like cause of pain, right? Maybe some ligamentous like stress, damage, rupture, partial rupture, maybe some muscular tearing, maybe a bone contusion in there. Like there is probably some, pathologic tie to pain. But what about somebody that's had chronic pain? Let's say they have that ankle sprain and 3 years later, they're still having ankle pain. Yeah, there could have still been, maybe there's, modic changes within that ankle. Maybe there's, subtle changes within the cartilage in between the subtalar joint or the mortise joint, and things like that can occur. But a lot of more often than not, I just saw a patient the other day that pretty normal functioning ankle, but they still have pain. And then we have to start asking, well, what's driving that pain response? This is, if we went to the extreme, we talk about things like chronic regional pain syndrome, where the sympathetic and parasympathetic response are way out of whack. And now you actually get physiologic responses with pain to non-pathologic scenarios, right? So you'll get discoloration, swelling, temperature change, all the things you would get with an actual acute injury, but without any injury, right? And it just kind of persists. And that's your nervous system running amok when you don't have a great response for a variety of reasons. But now that we were talking about, okay, that pain pathology tie, like why do we need pain besides just keeping us alive? Well, like I said, it's a sensation. So what would happen if we got rid of pain? Well, you wouldn't live very long. But the other thing is your feedback from your environment would be largely changed, right? So not just to the point of I would touch a hot stove and put my hand on it. I mean, there's neurologic disorders where people do not have a pain response. They have a lot of injuries, right? But it goes beyond that. The fact that you change positions, if I'm sitting in this chair so I don't end up with a pressure ulcer, my ability to change positions just so I don't have undue stress on passive and active soft tissues, aka ligament, tendon, muscle, bone. It's a feedback mechanism, no different than vision or taste or hearing. And what do we know with somebody that loses their sight? Well, they're going to reorganize parts of their gray matter that then make things like taste and hearing better, so that they now can perceive their environment a little bit better, even though they lost a sense. So what's one of the postulations of chronic pain? We talk about this idea of like cortical smudging, that when I've had pain, like let's say I had an ankle sprain and I just keep pushing through it too much. And like Laird Hamilton, world famous surfer, broke his ankle, just kept walking on it, ankle fused. There's a high likelihood that there's some cortical smudging where your brain starts to, the theory would be basically like admonish feedback in a certain part of the cortex so that your body can just keep going. Well, that's not great when it comes to movement, right? You've lost your feedback mechanism in that area, which was a pain response, which then what's your body have to do if you're going to shut off the pain response? You also have to tune or turn down the volume on things like proprioception, mechanoreception, which are position sense and mechanical position of the joints. That's not a fantastic thing if we don't want to alter movement up the kinematic chain. Just think if your ankle's messed up, not just based on movement, but like how you can move. Well, here, maybe we have problems, knee, hip, all the way up to, wherever. But also just the ability to keep things healthy. So if I have an ankle that doesn't move, what am I also not going to do? I'm not going to have as rich a vascular supply. The neurology is going to be affected peripherally, not just centrally with that cortical smudging. So a whole lot of things change when pain gets altered. And that gets way into the chronic pain stuff. And for those watching or listening, if you are a practitioner and you haven't read World of Hurt, you should. If you're a non-practitioner and you've never read like Pain Explained, like David Butler, those are really good resources to just go through a lot of this stuff. Now, when we get into the clinic, from a patient perspective, a lot of people come in and they would rightly or wrongly assume that their goal is to get out of pain. If you've been in pain, like if you have an acute injury, we want to get you out of pain, but we're actually trying to do what? Let things heal or get things to heal. If I've been in pain for a long time, let's say somebody's had low back pain for months or years, again, the likelihood of that being tied to pathology goes down and down as the timeline grows. And you may say, well, what about arthritis and degenerative change? There's a very low correlation between things like degenerative change, arthritic degeneration, and pain, right? So what do we tend to do with patients? We tend to talk about, like, especially if you're in chronic pain, okay, instead of our goal being getting out of pain, can we think about what would we want to do if we were out of pain? A lot of people, let's say it's a runner. Well, I want to be able to run. Okay, that's great. Let's get specific. Like, I want to be able to run this much per week. I want to be able to play with my kid. I want to be able to do X, Y, Z. A lot of people just want to say, well, I want to wake up not in pain. That's fantastic. Can you imagine if you said, well, I'm going to wake up and be able to see again? That's a much harder ask, right? So to say that I'm going to turn on or turn off sensation may be tough when that neurology is deeply seated or damaged sometimes. So we tend to look at pain in our clinic as an indicator, no different than blood pressure, right? if somebody came into a primary care physician, what we hope would happen is if they had an elevated blood pressure, let's say it's not acutely elevated, it's slightly elevated on a chronic level. So say for the past year, they've had 155 or 95, for a 50-year-old male, 200 pounds, 6 foot tall. That's a little bit high blood pressure. And we'd say, man, there's a higher risk of cardiovascular disease and stroke with elevated blood pressure. We're going to put you on blood pressure medication. There may be some talk in there of, there's dietary issues, stress issues, things like that may be causing the blood pressure, but rarely do I think it's actually ever like truly looked into of why is your blood pressure elevated? We have the panacea of why we know blood pressure is elevated, but why is it elevated with that person? Again, we're talking about, we back up to that study out of the Pain Journal, that we're a very individual species, and then every person within that species is very individual. So people deserve a fantastic exam to figure out, okay, your subjective response or subjective scenario with the pain you're experiencing is different than everybody else's. Let's use that pain as an indicator, but that's only an indicator of what else is going on, not that you have pain. That's just it's a dashboard light. So what should we be focused on if the goal is not necessarily to remove pain? Well, in our clinic, and this is up for debate, it would be changing function, right? Improving movement. Sometimes we would say improving tolerance. That could be for a variety of reasons. The talk of tolerance is maybe a runner that just did too much too fast, and some of those passive tissues, tendon and ligament, are up to snuff, and you're going beyond the capacity, and the response for the going beyond capacity is what? Pain. The other part of that could be maybe your aerobic system isn't up to snuff, like you're grossly out of shape. And now every time you try to do anything, you run right up into an aerobic deficit issue, which then causes you to, lack feedback because those proprioceptors are O2 reliant, and you become a little more clumsy. You move through your joints a little bit different, and here we are back in pain. So we should always be looking at something beyond pain. And it's not always just like, got to get your ankle moving better. It may be a systemic health thing. It may be, hey, you're in pain because of your major acute or chronic inflammatory markers are elevated. Well, that's a systemic health issue. What do we do something in our clinic? Do we refer you? Do we, just try to have general guidelines for, modifications of environment and health at home, whether that's movement, diet, sleep, hydration, right? The big pieces. And that gets into a big part of what we actually do in the clinic. It's not just, getting a joint moving, working on a soft tissue, loading people up so they become more tolerant. It's also exploring all these environmental issues to make sure that what we're doing in the clinic is actually going to be relevant to that person. Because if you're trying to put out a forest fire with a garden hose, and in that scenario, I'm talking about like if somebody has knee pain and they're 300 pounds overweight, taking like 10 different medications that may have cross interactions that have maybe pain as a side effect, or, poor response to pain alleviation. Like, we have to address that stuff, and we may not be able to address it because it's out of our scope, but at least we're going to be part of that medical team, and then, go out into their medical tree and have conversations where need be, or at least educate them as best as we can. And I don't want to pick on the medical system, but this is where like we're failing, not just systemic health, right? That blood pressure scenario where it's like, oh, your blood pressure is elevated, here's a pill. Why is it elevated? Well, it's not always just because somebody's a little bit overweight, somebody's a little stressed out. Like, make sure you're checking everything. And I just feel like that doesn't happen a whole lot. Well, the same thing goes for orthopedists, people within my field, PTs, chiros, trainers, coaches. Are we just treating what we see at a surface level? Are we actually going, through the process of what Toyota would call the 5 whys? Are we asking at least those 5 whys of, okay, you come into me today with back pain. Why is your back hurt? I had a back injury 10 years ago. Why does it still hurt? I've been told I have degenerative change. Why do you have degenerative change? Well, I was told I was never supposed to move that part of my back or bend forward, and I've been wearing a back brace. Why do you still wear a back brace 10 years later? Because I was told I was supposed to. Then you get to the question, why are you listening to that person? No, that's not the last why. But you keep digging in until you're at that linchpin, that the one thing, as Gary Keller would say, that's where you jump off. And if that's not in your scope, the best thing you can do for that person is refer them. And a lot of people would say, well, I want to get them feeling as good as they can. I can promise you one thing. If somebody has an elevated SED rate, elevated CRP, yeah, getting them moving has an anti-inflammatory effect. But again, I think it's a drop in the bucket, and maybe it's a catalyzing thing. You get them moving a little bit better, they get out a little bit of pain, maybe they start eating a little bit better. Like that's again, take that N=1. Like some people that is the case, some people it's not, and you have to go to that systemic side, and that's a tough ask of some people when their goal is to get out of pain and then say, hey, this is a lifestyle modification. But we've had numerous patients in the clinic where, you know, we either did this up front or we did it as we're going through the trial of care, where it's like, hey, you have to go through, you know, a pretty stringent elimination diet. You need to go talk with our health coach or functional medicine doctor, because we really think if you make these lifestyle changes, it's going to massively affect your subjective response, aka pain, to something that may not have any nociceptive input or bearing anymore. And welcome to current status of U.S. society and then healthcare, right? We're, you know, the obesity rate is over 50%. People move less than 1 hour a day. Children move less than sometimes even adults do now. Our children are the first generation that's pegged to live a shorter time frame than we are, and definitely more unhealthy lives. So a lot of that starts with like thinking about things like pain a little bit different, because maybe we're in more pain because we're not actually doing the things that humans are supposed to do, which takes us all the way back to the beginning of that evolutionary process of like, pain was normal. What do we used to do? Pain used to keep us from getting killed by a tiger, jumping out of a tree that was too tall, keep us safe while we did hurt something. So I hope that helps somebody out there. And if you're dealing with pain, chronic pain, here's my last little tidbit. You deserve more than commenting on my YouTube video here and asking me hey, I got knee pain, what's going on? You know, if you're going to work with me, like do a virtual consult, we'll try to do something, but try to find somebody good in your area. You deserve an exam, because why? You're an individual. You know, off the cuff, flyby advice, which is becoming even more popular because maybe that's another failure of the medical system. People feel a little left out in no man's land, that people are seeking out advice from Instagram and Facebook and YouTube, which I appreciate you guys watching the video, but this is not medical advice. This is me trying to say, like, this is a systemic issue. People need to understand parts of their body, aka you would hope that you understand vision a little bit, your taste, your hearing. So if somebody tells you, hey, you need a hearing aid or you need glasses or your kid needs braces, like why? Not just like, this is the reason. Like, this is your body. Like, you deserve to understand it a little bit.